Everyone. I'm so glad you're here. If you're studying for the ACVPM board exam, the NAVLE, or you're just trying to get a solid handle on how veterinary public health actually works, you're in exactly the right place. And this module is one of the most important ones in the entire series. Today, we're diving into surveillance systems and design. Surveillance is, without question, the backbone of veterinary public health. I like to think of it as the eyes and ears of the entire system. And here's the keys insight I want you to carry through this whole module. You cannot control what you cannot detect. If a disease is spreading silently and no one is systematically looking for it, you will always be behind. Surveillance is what puts you ahead. Here's our roadmap for today. We're going to start with a crisp definition of surveillance and how it differs from monitoring. Then we'll work through the 5 major types of surveillance systems. After that, we'll dig into the 8 CDC attributes you'll use to evaluate any system. We'll look at the major programs, WOA, NARS, and NARMS, and finally, we'll tie it all together by walking through how to design and evaluate a surveillance system from scratch. That last piece is exactly the kind of structured thinking the ACVPM exam rewards. Let's get started. Before we can evaluate or design a surveillance system, though, we do need to be crystal clear on what surveillance actually means and what it doesn't mean. Let's lay that foundation next. So let's start at the very beginning. What is surveillance? The classic definition, and the one you need to know cold for your exam, is this. Surveillance is the ongoing systematic collection, analysis, interpretation, and dissemination of health data for the purpose of public health action. Every word in that definition matters. Ongoing. It's not a one-time study. Systematic. It follows a structured, repeatable process. And critically, it exists for public health action. That last part is where a lot of people trip up. Surveillance is not just data collection. Data without action is just data. Think of it this way. If we're collecting salmonella culture results from broiler processing plants every week, but no one is analyzing those results, no one is looking for trends, and no policy is ever adjusted in response, that is not surveillance. It's data hoarding. True surveillance closes the loop from collection all the way to response. Now, what about monitoring? These terms are often used interchangeably in everyday conversation, but there's a meaningful distinction. Monitoring typically refers to tracking known parameters over time. Think of monitoring feed conversion ratios or tracking herd milk production. Surveillance is broader. It's specifically oriented toward disease detection and driving public health decisions. Think of the USDA's ongoing salmonella testing in broiler flocks. Data is collected, trends are analyzed, and when contamination rates exceed performance standards, establishment-specific interventions and policy changes follow. That complete loop is textbook surveillance. Now that we have a solid definition, let's step back and ask the bigger question before we get into mechanics. Why do we run surveillance programs at all? Next, we'll walk through the 6 core objectives and why every well-designed system starts by naming the one it serves. The different types of surveillance, let's step back and ask the bigger question. Why do we run surveillance programs in the first place? Here's the thing. Surveillance is never free. It costs money, time, and people. So every program has to earn its keep by serving a clear objective. There are 6 big reasons, and the exam loves to hand you a program and ask which objective it's serving. So let's work through all 6. The first is to detect new or emerging diseases, catching a novel pathogen or a new geographic spread before it ever reaches epidemic potential. The H5N1 avian influenza sentinel poultry programs are the classic case. We deliberately watch a sentinel population so the virus shows up on our radar early. The second is to monitor disease trends, tracking prevalence and incidence over time so we can actually tell whether a control program is working. USDA's brucellosis eradication monitoring is the textbook example here. And the third is to establish a baseline, which is the one people tend to overlook. You can't recognize, quote, abnormal until you know what, quote, normal looks like. The NAMS National Prevalence Surveys quantify that normal disease burden, so a deviation jumps right out at you. Reasons 4 through 6 rounded out. Guiding resource allocation, using surveillance data to point your vaccines, diagnostic capacity, and personnel toward the highest risk areas and species, which is exactly what risk stratified deployment is about. Supporting trade certification, generating the evidence of disease freedom or controlled status that WOA requires for international trade, like FMD freedom surveillance. And finally, evaluating interventions, measuring whether your vaccination campaign, culling program, or movement restriction actually moved the needle on disease frequency. That's why we run pre and post vaccination campaign monitoring. Without it, you're just hoping it worked. The big takeaway: a well-designed surveillance system always starts with the objective. When you sit down to design or critique a system on the exam, the very first question is always, what is this for? Everything else, passive or active, which populations, how sensitive it needs to be, flows from that answer. With the why firmly in hand, let's turn to the how. The most fundamental distinction you'll be tested on is passive versus active surveillance. So let's break those two down next. Passive versus active surveillance. This comparison comes up on virtually every EPI exam, so let's get it locked down. Passive surveillance is exactly what it sounds like. The data flows to the system without the system actively going out to find it. Veterinarians, diagnostic laboratories, and producers submit reports because they're required to by law or because they choose to, and those reports are compiled and analyzed. Mandatory disease reporting is the classic example. When a veterinarian diagnoses foot and mouth disease and calls the state veterinarian, that's a passive report entering the surveillance system. The advantages of passive surveillance are real. It's low cost, it operates continuously, and it covers a broad geographic area without enormous infrastructure. But the limitation is critical. Passive surveillance almost always underestimates true disease burden. Why? Because it only captures cases that are detected, diagnosed, and then actually reported. If a producer doesn't call the vet, if the vet doesn't submit a report, or if the disease presents atypically, it never enters the system. Active surveillance flips that dynamic. The system goes out to find cases through scheduled herd visits, population surveys, targeted testing programs, and slaughter inspections. The USDA NAMS surveys, where staff actively contact randomly selected farms, collect samples, and generate nationally representative disease estimates, are the examples shown here. Active surveillance is more resource intensive and more expensive, but it gives you a far more complete and accurate picture of disease burden. Here's a great exam question to sit with. If you're designing a surveillance program for BSE, a rare, devastating, internationally notifiable disease where every case matters, do you want passive or active? And how does that compare to your approach for endemic ringworm in a mixed species practice? Think about sensitivity, cost, and the consequences of missing a case. Here's an ACVPM exam tip. Passive surveillance underestimates true disease burden due to reporting bias. Cases must be detected, diagnosed, and reported to enter the system. Missing any step means missing the case. Active surveillance is preferred when sensitivity is critical, specifically in eradication programs such as brucellosis, for rare, high consequence diseases like BSE or FMD, or when establishing true prevalence for a naive population. Expect at least one question asking you to choose between passive and active given a specific scenario and justify your reasoning. Passive and active are the two big categories, but they're only the start. Next, we'll open up the full surveillance toolkit: sentinel, syndromic, laboratory-based, event-based, participatory, and mortality surveillance, and see the specific niche each one fills. We've already locked down passive and active surveillance, so now let's fill out the rest of the toolkit. This slide lays out 6 more surveillance approaches, and each one is engineered to do something the others can't. Let's walk through all 6. Sentinel surveillance uses a carefully selected subset of sites or animals as representative indicators, giving you fast, low-cost early signal detection. The placement is deliberate. You put your sentinels where exposure is most likely to happen first. The classic veterinary example is sentinel flocks for avian influenza positioned at live bird markets, and the same logic drives sentinel chicken flocks for West Nile virus, where the birds seroconvert and warn us the virus is circulating before horses or people get sick. Syndromic surveillance monitors clinical signs or syndromes rather than waiting for a confirmed diagnosis, which makes it faster than any lab-confirmed system. Picture clusters of respiratory disease in pigs being reported to state veterinarians. You can launch an investigation off that pattern days before a specific pathogen is ever named. Laboratory-based surveillance systematically tracks positive results across a diagnostic network, giving you confirmed pathogen data. NARMS is the marquee example, tracking salmonella resistance across food animals, retail meat, and humans straight from the lab bench. Event-based surveillance, or EBS, pulls informal signals from non-traditional sources: news media, social media, and practitioner networks. Platforms like ProMed, HealthMap, and GPHIN scan that chatter for the first whisper of an unusual event anywhere in the world. Participatory epidemiology engages communities and producers directly, drawing on their local knowledge. It's especially valuable in resource-limited settings and for wildlife where formal reporting infrastructure simply doesn't exist. Community-based reporting in LMIC livestock systems is the textbook case. Mortality surveillance tracks animal death rates and patterns as a sensitive early indicator of disease emergence, while bird die-offs monitored by USGS, for instance, act as a sentinel for HPAI long before the virus surfaces in commercial poultry. The ACVPM exam loves matching questions. Which type fits this scenario? Commit these 6 to memory alongside passive and active, and you'll handle those with confidence. Now that we have the full toolkit of surveillance types, we need a way to judge how well any given system actually performs. That's where the CDC's 8 core attributes come in. Let's evaluate. This slide is genuinely one of the most testable topics in veterinary epidemiology. The CDC updated guidelines from 2001 give us a standardized framework of 8 attributes for evaluating any surveillance system. You need to know all 8, what each one means, and, crucially, how they trade off against one another. Let's walk through them as they're grouped here. Sensitivity, the proportion of true cases the system actually detects. Low sensitivity means missed cases and silent spread. The iceberg stays underwater. Specificity, the proportion of alerts that turn out to be true disease events. Low specificity means false alarms that drain resources. Timeliness, the speed from occurrence to detection to response. It's critical for fast-moving pathogens like HPAI or FMD, where delays are measured in premises and lives. Representativeness. Does the system capture disease across all populations, geographies, and species? Gaps become blind spots. Simplicity. How easy the system is to operate, report into, and analyze. Complex systems fail through practitioner non-compliance. Flexibility. Can it adapt to new pathogens, new case definitions, or new reporting structures without a full rebuild? Acceptability. Are practitioners and producers actually willing to participate? It's the most chronically underestimated attribute because a system nobody uses is worthless. Positive predictive value, or PPV. Of all the cases the system flags, what proportion are real? It's shaped by both specificity and the underlying disease prevalence. Here's the critical insight. No surveillance system excels at all eight at once. Trade-offs are inevitable. Maximizing sensitivity catches more cases, but generates false alarms and erodes PPV. Tightening specificity cuts the noise, but risks missing an incursion. Designing and evaluating surveillance means consciously making those trade-offs in line with the system's primary purpose. Here's an ACVPM exam tip. Know all 8 CDC attributes by name and definition. A very common question asks, which attribute is most compromised by underreporting? The answer is sensitivity, because if cases aren't reported, the system isn't detecting the true proportion in the population. A second favorite pairs sensitivity with PPV. Be ready to explain why adjusting a case definition pushes one up while pulling the other down. Now that we have our evaluation framework, let's shift to the major programs operating in veterinary surveillance, starting at the international level with WOA and the globally notifiable disease list. Let's zoom out to the international level. The World Organization for Animal Health, known as WOA, formerly the OIE, is the intergovernmental organization responsible for improving animal health globally. One of WOA's most critical functions is maintaining the international list of notifiable diseases, diseases that have the potential for rapid transboundary spread, significant socioeconomic or public health consequences, or major impacts on international trade in animals and animal products. The criteria for WOA listing are specific. The disease must have demonstrated international spread potential or significant zoonotic risk or major trade implications. Examples you should know by heart: foot and mouth disease, FMD, highly pathogenic avian influenza, HPAI, African swine fever, ASF, and rinderpest, which was officially eradicated in 2011, the first animal disease ever eradicated globally. Knowing rinderpest's history is also a strong signal of your depth of understanding. Member countries, and the U.S. is a member, have legal obligations under the WOA framework. For immediate notifications, countries must report the occurrence of a listed disease within 24 hours. Regular ongoing disease status reports are submitted weekly through the WAHIS system, the World Animal Health Information System. WAHIS is WOA's online platform and it's publicly accessible. You can look up disease status by country and disease in real time. Here's the distinction that trips people up. WOA's list is the international reporting obligation, but each country also maintains its own national list of reportable diseases, which is typically longer and includes diseases of domestic concern that may not rise to the WOA threshold. In the U.S., that national list is managed through USDA APHIS Veterinary Services. Veterinarians have a legal obligation to report listed diseases. Failure to report is not a judgment call. It is a legal and ethical breach. WOA Freedom Certification raises a deeper question that trips up a lot of candidates. How do you ever prove a disease is absent? Next, we'll tackle exactly that, demonstrating disease freedom using system sensitivity and scenario tree modeling. Here's a question that sounds almost philosophical but is deeply practical. How do you prove a disease is absent? You cannot prove a negative, absolutely. What you can do, and what this slide is all about, is demonstrate with defined confidence that if disease were present at or above a chosen prevalence, your surveillance would almost certainly have caught it. That's the entire logic behind proving disease freedom. Start with design prevalence. This is the minimum prevalence level that actually matters for management decisions, the threshold at which you'd want your system to detect disease if it were present. Depending on the severity and consequence of the disease, it's typically set somewhere between 0.1 and 5%. You're not trying to rule out a single hidden animal, you're ruling out disease at a level that would matter. Next comes system sensitivity, or SSE. This is a probability that your surveillance system detects at least one case if disease is truly present at the design prevalence. The keyword is system. SSE combines the sensitivities of multiple imperfect surveillance streams into a single overall estimate. And this is where scenario tree modeling earns its keep. Look at the components on this slide. Slaughter surveillance at 62%, abattoir serology at 54%, high-risk area surveys at 45%, and farm-level reporting at 38%. Not one of those on its own would convince anyone a country is free of disease, but scenario tree logic combines them, weighing each by the probability that a sampled animal actually comes from an infected unit. And the combined system sensitivity climbs to 95% or higher. That's the headline insight. No single component has to be perfect. Finally, this is what underpins WOA compliant freedom demonstration. Official disease freedom status for international trade isn't a declaration. It requires documented surveillance achieving defined SSE targets over defined time periods. That documentation is what governs billions of dollars in global livestock commerce. Here's an ACVPM exam tip. When a question asks how a country demonstrates freedom from a disease, the answer is system sensitivity, SSE, combined through scenario tree modeling, not the sensitivity of any single diagnostic test. Remember the principle that multiple imperfect surveillance streams combine to reach a target SSE, commonly 95%, at a defined design prevalence. Be ready to explain why you can never prove absolute absence, only freedom at or above a stated prevalence. We've shown how surveillance can prove disease is absent. Now we flip to the opposite problem. Once disease is present, how do we spot the signal of an outbreak in all the day-to-day noise? Surveillance systems generate a constant stream of counts, and the hard part isn't collecting them. It's telling a real outbreak apart from random variation, reporting artifacts, or a change in diagnostic testing, all of which can mimic a genuine rise in disease. This slide walks through the four main analytical methods we use to spot that signal. Epidemic threshold is the simplest. It's the count above which observed disease frequency is treated as an outbreak, the level that exceeds the expected baseline. That baseline is built from historical data for the same time, place, and population, so you're always comparing like with like. Statistical process control borrows control charts from manufacturing. Methods like QSUM and EWMA monitor disease counts over time and trigger an alert when observed counts breach the control limits. You'll see this applied in abattoir surveillance and milk quality monitoring. Time series methods go a step further by using regression models that account for seasonality and longer-term secular trends. Influenza-like illness surveillance is the classic case. You define an expected case count for each week of the year, then watch for deviations from that week-specific expectation. Spatial cluster detection asks a different question, not just how many, but where. Scan statistics like SAT-SCAN identify geographic clusters that exceed the expected spatial density. This drives FMD response planning and tick-borne disease monitoring across livestock regions. The thread tying all four together is the key challenge on this slide, distinguishing a true outbreak signal from background noise. A spike in reported cases might be a real epidemic, or it might be a new lab test, a reporting backlog, or ordinary seasonal variation. These methods exist to tell those apart with rigor instead of guesswork. Detecting outbreaks within a system is powerful, but disease doesn't respect the boundary between animal and human health. Next, we'll look at how One Health surveillance connects those systems together. Disease at the animal-human interface doesn't care which government agency is responsible for it, but our surveillance systems often do, and that's exactly the problem this slide opens with. The siloed system failure is the starting point. In many countries, the Ministry of Health runs human surveillance while the Ministry of Agriculture runs animal surveillance. Different data formats, separate reporting chains, zero interoperability. The result is dangerously slow detection of zoonotic spillover events precisely when speed matters most. At the global level, the Global Health Security Agenda and its joint external evaluations push back against that fragmentation. JEES formally assessed each country on its human-animal health interface capacity, scoring veterinary surveillance right alongside human health. That's a formal IHR-compliant mandate for integrated systems. The model program to know cold is NARMS, farm to fork to patient. It tracks the same isolates, Salmonella, Campylobacter, E. coli, through food animals at slaughter, retail meat, and human clinical samples run jointly by CDC, FDA, and USDA. That three-stream design is what makes it a genuinely functioning One Health system, and it's the gold standard example for your exam. Underneath all of this sit the electronic reporting platforms that make near real-time sharing possible. Impress from FAO, WAHIS from WOA, plus ProMed and HealthMap. They move disease event information across the human and animal health sectors almost as it happens. And the horizon is moving fast. AI-powered event-based surveillance, scanning social media and clinical records, predictive spillover modeling, and digital livestock ID that enables instant traceback from farm to outbreak. That's where integrated surveillance is heading. Here's an ACVPM exam tip. NARMS is the gold standard example of a functioning One Health surveillance system because it tracks the same isolates across three independent streams: food animals, retail meat, and humans. Always name all three agency partners: CDC, FDA, and USDA. If a question asks what makes a surveillance program a One Health program, the answer is its simultaneous monitoring across the human-animal-food interface. We've connected animal and human systems, but every one of these systems shares a hidden weakness. They only ever see a fraction of the disease that's really out there. Let's confront the underreporting problem next. Here's a humbling truth that sits underneath every surveillance number you'll ever see. Every case count is a gross underestimate of true disease burden. 200 reported cases of equine influenza might represent 2,000 or 20,000 true cases. This slide breaks down why that happens and what we can do about it. The reporting pathway is a leaky pipe, and disease can drain out at every single step. The animal may never be seen by a veterinarian. Subclinical disease, a remote location, or an owner worried about cost. The disease may not be diagnosed because of limited testing, an unfamiliar presentation, or no lab access. It may be diagnosed but not reported out of unawareness, fear of economic fallout, or simply the time burden of filing. The report may be filed but lost in a paper system or a broken chain. Or the laboratory may never be notified because a clinical diagnosis was made without confirmatory testing. Miss any one step and the case never enters the system. The good news is that epidemiologists have a real toolkit for correcting these gaps. Multipliers apply empirically estimated ratios of true cases to reported cases. The CDC estimates only 1 in 30 human salmonella cases ever reaches the surveillance system. Capture-recapture methods borrowed from wildlife ecology use the overlap between two independent surveillance sources to estimate the total burden, including the cases neither source saw. Modeling is the third approach, using known test sensitivity, reporting rates, and healthcare seeking behavior to reconstruct true incidents from reported counts. And sentinel site intensification takes a handful of sites, surveils them intensively, and uses them to estimate the reporting fraction across the broader passive system. The exam takeaway is blunt. Never interpret a raw passive case count as complete. That 1 to 30 salmonella ratio is the number people remember. Let it anchor your instinct that what you see is the tip of the iceberg. Underreporting, representativeness, sensitivity, these all trace back to choices made when a system is first built. So let's put it all together, the 8 questions you have to answer to design a surveillance system from scratch. This is where everything converges into practice. Whether you're a state veterinarian, a public health official, or an ACVPM candidate working a case scenario, designing a surveillance system comes down to a structured set of decisions. This slide lays out 8 questions you have to answer first, and they map directly to how the exam evaluates this competency. Question 1. What is the objective? Are you detecting an emerging disease, monitoring an endemic one, certifying freedom, or evaluating an intervention? Every later choice flows from this answer. Question 2. What population, the species, geographic scope, and production type you're watching? Question 3. What disease or diseases? This is your case definition, diagnostic criteria, and whether you're counting clinical or lab-confirmed cases. It's the most technically demanding decision because it shifts sensitivity and PPV in opposite directions. Question 4. Active, passive, or both, driven by your objective, your resources, and the sensitivity you need. Question 5. What data sources? Labs, practitioners, abattoirs, farms, mortality records. Each brings different coverage and different blind spots. Question 6. Data collection and management. Paper versus electronic, the forms, the database architecture, all of which shape data quality and timeliness. Question 7. What is the required system sensitivity? Set this by the disease consequence and the program objective. A catastrophic exotic disease demands far higher SSE than an endemic one. And question 8. Who gets the outputs, when, and how? Report formats, frequency, audience, and critically, feedback to the people doing the reporting. That last point is the design principle on this slide, and it's the one people forget. Surveillance systems succeed when stakeholders understand why they report, see the data come back to them, and believe it matters. Build those feedback loops in from day one. With the design framework in hand, we've now covered the full arc of this module. Let's pull the essentials together into a rapid review you can carry straight into the exam. We've covered a lot in this module, so let's take a moment to consolidate, because the way you organize this material in your memory is going to determine how well you perform on exam day. Here are your core takeaways from this module. Surveillance is defined by action, not just collection. The loop from data collection through analysis, interpretation, and public health response is what distinguishes surveillance from data accumulation. Know your 5 surveillance types and when to use each. Passive, low cost, wide coverage, underestimates burden. Active, high cost, more complete, preferred for eradication. Sentinel, early signal detection. Syndromic, pre-confirmation, outbreak detection. Participatory, community-based, resource-limited settings. Memorize the 8 CDC attributes. Sensitivity and timeliness appear most often on exams. Know how adjusting a case definition affects sensitivity and positive predictive value simultaneously. Know WOA, NARS, and NARMS code. WOA, International Notifiable List, 24-hour reporting, WAHIS system. NARS, USDA State Cooperative, voluntary reporting, livestock and poultry focus. NARMS, CDC, FDA, USDA, One Health AMR surveillance for enteric bacteria targets. Apply the structured design and evaluation framework. When a question asks you to design or evaluate, work through the 6 design questions or 8 CDC attributes systematically. Never offer a general critique. Always tie it to a specific attribute and follow with a specific recommendation. Here's the mindset I want you to leave with. If you understand why surveillance systems are designed the way they are, what trade-offs they're making, what populations they're missing, what delays they're accepting, you will not just memorize the right answer, you will derive the right answer, even for questions you've never seen before. That's the difference between a student who passes and one who excels. You've got this. I'll see you in the next module, a module about screening programs, where we'll look at how to evaluate the performance of diagnostic tests used to identify disease in individuals and populations. It builds directly on what we've done here today. If you found this information useful, please like and subscribe so you don't miss any modules. Thanks, and I'll see you next time.